penalty schedule for FHA loans that are in default?
I don't know that I can say broadly. I think you.
Well, I'm asking you to state specifically.
I think you got to look at specific cases. In some cases, I might be in favor of it. In some cases, I might not.
Okay. Do you know what the interest rate curtailment schedule is at FHA and how it's different from the GSEs?
Well, we tend to try to maintain a lower interest rate at FHA.
I'm not asking you about the interest rate, sir. I'm asking you about debenture interest curtailment penalties.
Explain.
So, all right, so FHA uses different servicing and conveyance procedures than the GSEs do. And the result of this is that the cost of servicing, mortgage servicing at FHA for a non-performing mortgage is 3 times the cost of doing the equivalent servicing at the GSEs for a non-performing loan. That tripling of cost in servicing, which then has the effect of reducing the credit availability to the American people, because when you drive up servicing costs, then servicers overlay with cost overlays, and it makes the loans more expensive for the very homeowners that FHA is designed to serve. So my question I'm trying to drive at here is, why is FHA, to use a term that I think we can both understand, lousy at servicing mortgages?
Okay, I have not had any discussions about that particular issue, but I will look it up, find out what's going on.
So as you look it up, I'd also like you to get back to me, if you don't mind, to explain the disparity in REO rates. Do you know what an REO is?
An Oreo?
No, not an Oreo. An REO. REO.
Real estate?
What's the O stand for?
E organization?
Owned, real estate owned. That's what happens when a property goes to foreclosure. We call it an REO. And FHA loans have much higher REOs. That is, they go to foreclosure rather than to loss mitigation or to non-foreclosure alternatives like short sales than comparable loans at the GSEs. So I'd like to know why we're having more foreclosures that end in people losing their homes with stains to their credit and disruption to their communities and their neighborhoods at FHA than we are at the GSEs.
I would be extremely happy if you'd like to have you work with the people who do that.
Well, Mr. Carson, respectfully, that was my day job before I came to Congress. So now it's my job to ask you to work with the people.
I'm talking about the people at HUD who do that.
I've spent a decade working with the people at HUD on this problem. So what I would like you to do is to take this back to FHA and to ask the folks at FHA, because since 2007, I have been writing about the problems in FHA's servicing. I am a huge fan of FHA. I am a believer in their mission, and I am a champion for them. Are you?
Of course, I believe in the mission of FHA.
Are you a champion for the institution, the organization?
Very much so.
Okay, so let me make sure you understand. When a loan, the most common outcome for an FHA loan that goes into default is REO. There's a conveyance process. Are you familiar with this?
I know about the conveyance.
All right, so let me ask you about conveyance. What actions is HUD taking to change the conveyance process at FHA to address the loss recovery differential between FHA loans and GSE loans?
Well, again, you're getting way down in the weeds here. And
because it's real American people are out of their houses, so they are literally in the weeds when they are foreclosed on.
Understood. And I'm very happy to put you in contact with the people who deal with that. If I got down in the weeds on every issue, I wouldn't get very far.
Okay, appreciate it, but this has been a problem for years. The Urban Institute issued a major report on this, and I will be happy to send you a copy.
I appreciate you bringing it to my attention.
I want to make sure let me ask you this. Given these problems, the outcome is that FHA is the leading cause of blighted homes in the United States. What can you do about that? Do you understand the relationship between the blight and the servicing problems?
Well, I understand that blight is a huge problem and that
it comes from your agency's inaction on servicing.
I'm not sure that I'm willing to accept that FHA is the cause of all the blight that we have.
I hope you feel differently after you read the report. Thank you.
Thank you. Senator Cassidy.
Thank you. Let me just follow up right there, Ms. Arthur. You allude to it in your testimony, and going back to what Ranking Member Burr said earlier, Congress gave $1 billion to CDC to upgrade information systems. And I was specifically asking last year for more money for immunization information systems, and was told that billion was going out to states in order to upgrade, that's where it was targeted, because I was frustrated with CDC's inability to give real-time data. Now, so it seems as if we're advocating for dollars, of which $1 billion has already been appropriated, and we're told this is where it went. But Mr. Becker, in your testimony, you indicate that in Washington State there has been inadequate money to upgrade the immunization information system. I say that because it seems like there's a disconnect here. We gave $1 billion. I was specifically told it's going to go to upgrade state information systems, and I'm hearing from a very innovative state that you have inadequate resources to upgrade. So let me ask, did you receive money from that $1 billion that we gave CDC last year?
Thank you, Senator. I will have to go back and find out how much Washington State actually received from the CDC, but I can tell you that whatever we received was not adequate to meet the needs of what we have faced today.
Now, it could be that the state used it for something else. Let's just be fair to CDC, unless they came down with a specific instruction to spend it on immunization information systems. But it does seem, let me just ask, in your testimony, you do mention that you had a hard time keeping track. But this is exactly what immunization information systems are supposed to do. Why was Washington State's not adequate to do so?
So thank you, Senator. It's just the scalability, interoperability that I mentioned in the very first part.
But in the interoperability, you mentioned about EHRs, but the way if a child is given a measles, mumps, rubella vaccine, the provider actually enters that. And we've had other states come in here and testify that their IIS is currently accepting adult immunizations on COVID. Now, I guess I'm just exploring. I'm not trying to accuse. I'm just trying to understand why this is not the case. Why isn't it the case in Washington?
I think it's the disparate system. So you have very big hospital systems that can invest the infrastructure to send those things seamlessly. You have private providers that don't have that access.
What I'm not sure about, though, if a pediatrician is sending measles, mumps, rubella in that big hospital system, clearly the mechanism occurs. I won't belabor, but it does seem I'm just not getting a clear picture into what the problem is. We give $1 billion to CDC, somehow it's not happening, and yet the system works for childhood immunization, but it's not working for adult. I won't belabor. Dr. Jantz, I think one thing is clear. You mentioned in your testimony the need to have uniform standards of care. Fecal material is hitting the fan, and we don't have enough ICU beds. I probably used that line in my diarrhea lecture. We don't have enough ICU beds, but then we learned that we're putting too many people on ventilators. And putting on ventilators at too early a stage actually was associated with negative outcomes. I have to think that there's probably uneven uptake of that information in ICUs across the nation. I don't know that. I'm just assuming. How do we establish that uniform communication of care when how we manage a ventilator patient to ventilate or not really is critical in terms of both ICU utilization but also the patient's survival?
Yeah, thank you, Senator. It was vital for us to be able to spread evidence-based medicine, how to prevent patients.
How did you do it?
Via the Louisiana Department of Health and the Department of Health and Human Services, when we conducted seminars with hospitals around the state and the nation where they asked us, how do you solve these specific operational problems? We gave them answers.
Now, were you also able to give them like a checklist?
Yes.
So you were?
Yes, we shared with them all of the materials we developed in our own hospital. We stepped outside of the silo of an individual hospital system and shared all of our...
I don't mean to interrupt, but I'm almost out of time. And you went nationally. Who sponsored your national outreach?
ASPR, with the Department of Health and Human Services.
So hats off to ASPR for pulling that together.
Absolutely.
And were you able to demonstrably see that that how patients were being managed kind of stayed in lockstep with best practices across the nation?
Yes, it did catch up over time into what
Now,
is...
over time, how long over time? A month, a week?
Oh, on the scale of weeks. It was very quick. The feedback I got from hospitals around...
One more thing. You know, we were short. I got a call from an anesthesiologist in San Francisco when things were really bad in New Orleans. He goes, we've shut down electives, but COVID hadn't hit us yet. We should be shipping all our machines to you, and then you ship them back when it hits us. Because we understood there was going to be an uneven kind of implementation on it. Never happened. Instead, we're scrounging to build new ventilators when they were sitting idle in many parts of our nation. I just say that because I do think part of what we are doing here would be to source existing resources where they're needed from one part of the nation to another, as opposed to attempting to build from scratch a lot of machines that are very sophisticated, but then we don't need them when it's all done. So anyway, with that, I thank you all for your service and your testimony.
Thank you. Senator Smith.
Thank you, Chair Murray and Ranking Member Burr. I really appreciate this bipartisan hearing. I'm